Our final panelist is Dr. Shahzad Mian. He'll be giving us a case discussion. Is it a tumor?
Thank you. That is definitely an homage to Carol Karpf. I just kind of want Juanita Bond to actually say that title. So this is a case, I have no financial interest, of a 19-year-old who reports a yellow growth in the right eye noted 3 weeks prior to presentation. He reports mucus but no pain, redness, tearing, or change in vision. It's important to note that the eye exam that was documented in the chart was at 7 weeks prior to this, that there were no ocular lesions noted. On examination, the vision is 20/25 in both eyes, the pressures were normal, extraocular motility was full. And this is the slit lamp exam for the eye that's involved. I'll show you another picture as well, showing a vitiliform, well-circumscribed growth that involves the limbus going from the conjunctival side to the corneal side with superficial vessels. So based on this exam and findings, what is the most likely diagnosis? Hopefully your phones are going to work. So we have a winner of juvenile xanthogranuloma. You guys are smart. And I didn't show you the external exam, which is your bigger clue that this patient has diffuse skin involvement along the eyelids. This is a close-up of the external exam. And so again, the diagnosis is juvenile xanthogranuloma. So what's the most appropriate next step in management of this 19-year-old with this 3-week history of growth and when the vision is 20/25 in this eye? So this is the next question for you. Should we use topical steroids, intralesional triamcinolone, perform an incisional biopsy, or try to do an excisional biopsy at this point with a patch graft? Some variability between injecting, excising with patch graft, and maybe just topical to start with. So the decision was made to use topical therapy because the vision at this point was good. This was a new onset lesion involving the corneal surface with risk of surgery. After 1 month follow-up, the vision was still good, 20/20. There was perhaps some increase in size noted of the conjunctival and corneal involvement. Even at the initial presentation, the patient was following a pediatric hematologist oncologist, was started on a 28-day course of oral prednisone, as well as a 4-week course of vincristine, which is something that's used routinely for JXG when there is significant systemic involvement. Dexamethasone was also injected into the lesion at this point and into the inferior fornix as a subconjunctival injection. At 3-month follow-up, the vision remained good, but the growth and the lesion were still about the same size, and there was concern that this was going to get bigger. Again, no significant improvement with first topical, then intralesional, as well as ongoing systemic steroids and chemotherapy. The plan was made to perform an incisional biopsy with an amniotic membrane overlay. The biopsy was consistent with infiltration with macrophages and the classic Teuton giant cells present. 1 month after the excisional biopsy, the vision had actually decreased to 20/40, and the appearance I'll show you. So this was pre-excision, and this was post-excision. So it had a significant fibrotic response, but flattening of the corneal surface, which likely caused some of the vision loss, but stabilized the growth. The patient came back 2 years later, noticing some worsening of vision. Vision had decreased about 20/50, and there was a recurrent elevated yellow lesion with involvement in a similar location. Another incisional biopsy was performed with amniotic membrane overlay, and this was the post-treatment 1 month after repeat excision and amniotic membrane, where the vision has now decreased to 2400 with increasing size of the infiltration. Now, the infiltration, it's important to note, is essentially full thickness in the cornea and involves all the way to the limbus. And you can see the clock hours involved are at least 5. So 6 months go by, the vision is about the same, about 2400, and the examination findings are not improving. But the other eye also has a lesion, but in the other eye, it does not involve the cornea, it's peripheral. So it's relatively easy to manage, and the growth was removed. 4 additional years go by, and you can see the growth has expanded, but there's also a second area that's involving the cornea. And at this point, the vision is continuing to decline. You can see why it would be declining, because so much of the cornea is involved. So at this point, the decision was made to perform a penetrating keratoplasty because of the decrease in vision. And the complicated course over the following 2 years was that there was a perforation at the graft-host junction because of the suturing to this area where it involves the limbus. There was graft failure, a repeat corneal transplant, and eventually the patient ended up having a keratoprosthesis with a pars plana vitrectomy and a glaucoma drainage device. So this is the appearance 7 years after that. So this is 13 years after the initial presentation, with vision that's remained relatively stable but declined from its initial presentation. So juvenile xanthogranuloma, just a few words, is a non-Langerhans cell histiocytic inflammatory tumor. The most common clinical presentation is nodular skin lesions, but it can involve other organ systems, including the central nervous system, liver, spleen. Ocular involvement has been reported to occur in up to 10%, and this is where we think of the classic cause for spontaneous hyphema, and when it involves the iris. This patient never had any intraocular involvement. Corneal conjunctival involvement, as you can see in this case, can obviously occur, and posterior segment involvement has been reported as well. In most patients, these tend to regress before the age of 5 to 6. Management can include all the options that we use in this case, including immunosuppression with corticosteroids of various forms, and steroid-sparing agents, including methotrexate, have been used as well. Radiation therapy has been reported, and surgery, perhaps performed earlier, or if it does not involve as much of the cornea, could be performed with a patch graft. That's it. Thank you.
Thank you, Dr. Mann.